Hello, everyone, and thank you for joining us for this third program in the series with the COVID infection moving through the country. I think there is a need to have serious discussions about how to manage various patients with malignancies who might be affected by this disease, and also to continue to talk about the strain on the healthcare system, including obviously everybody who provides care to patients with cancer or otherwise. And we thank you for joining us on this holiday weekend. Happy Passover and happy Easter to those of you who celebrate these events. And we ask you to pray for all of us and all of those affected by COVID. We have another really good program for you. We are looking forward to having your questions submitted so that we can address them as we go through the program. Just as a reminder, we have several speakers. They will introduce themselves, then they'll cover a pre-assigned topic for about 5 or 6 minutes. And then once everybody is done with their presentations, we will take questions and go over some of the questions that you have submitted. There are no slides. This is completely a town hall setting and format, and we really would like to have your participation, so please submit your questions. With that in mind, I'd like to introduce the co-lead of this program, Dr. Hope Rugo. Dr. Rugo.
Thanks very much, and good morning, everyone, wherever you are in your geographic location. And it's wonderful that we're able to have another town hall here on Saturday morning to talk about COVID-19 and its impact in oncologic care, really a critical issue for a field which has rapidly expanded and is providing more and more curative and effective therapies. We really need to understand how a pandemic like this affects our patients, how best to protect them, and what we should be doing. And with that in mind, today we've gathered together people with special expertise in a variety of different malignancies to talk to you, and most importantly, to answer your questions, which is a really wonderful part of this forum. I'm Hope Rugo from the University of California, San Francisco, where I'm a breast oncology specialist. And to start off our morning, it's my pleasure to introduce Dr. Nina Shah, who's going to talk about the impact of the COVID pandemic, as well as the approaches that have been taken to manage patients with heme malignancies receiving cell therapy and transplantation. Thanks for joining us, Nina.
Thank you. Thanks so much for having me here on a Saturday morning, and hope that everyone is doing well and staying safe. I'm going to talk a little bit about transplant, cellular therapy, and hematologic malignancies in general and management thereof during COVID-19. I will leave the myeloma portion to my colleague, Dr. Saad Usmani, who will be coming after me. So I want to divide it into a couple of groups just in the few minutes that we have. First, our general things about hematology. We've sort of changed things to be more resource parsimonious. And so, for example, we've changed transfusion levels. A lot of times we were thinking about hemoglobin of 8. Now we think about hemoglobin of 7 if people are asymptomatic. And that's actually helped us to reduce our transfusion burden a lot. In addition, we've changed platelet transfusion, really trying to stick to 10 to conserve products. Regarding stem cell transplant, this has been a really up and down and confusing topic for a lot of us. And I think the first thing that we have to know in general for all hematologic malignancies, and probably for all of malignancies in general, is that what you do at your center depends on your center and your region. And so there are things that may be taking place in certain areas of the country, certain steps that are being taken, but those are not being taken in other areas of the country. And they may change over time depending on which part of the country has what kind of surge. And we also had a similar situation where we acted early, and then now we are trying to let in a little more people than we did before. So regarding transplant, and most of these situations clinically, it's about the urgency of the procedure. So for example, if somebody has an emergent leukemia transplant with a fresh donor that has to be done, then in that case, it seems like the benefit outweighs the risk, and we have proceeded with transplant. However, we have a lot more flexibility now. For example, NMD NMDP is allowing for frozen product so that patients or donors can be collected, but the transplant can be put off to when it seems like the recipient hospital will be more able to accommodate needs. And because of that, for example, we've put off some patients that may have gotten a transplant a couple of weeks ago, and we were just waiting to see what the situation was going to be like, not only because of the general immunosuppression of a transplant, but also due to hospital resource allocation and wanting to make sure that we can provide the best care that we can, which often does include ICU stay for some of these transplant recipients. Because of this, we've been able to see the pattern in the hospital. And now we know that, for example, for emergent collections or emergent transplants, we can proceed. But for collections and transplants that maybe can be put off, we could do the collection. We could have the collection be done somewhere else. If the donor has to fly in, we actually don't want that to happen. So for donors that may be stuck in San Francisco and we're going to go somewhere else, we'll collect them. Or for donors that were stuck somewhere else and we're going to come here, they'll be collected somewhere else. And then we would allow the product to fly, but the donor doesn't have to fly. Again, minimizing the risk to the donor. So those are the things that we've done for allo. And then again, if the patient really does emergently need the allo transplant, we have been proceeding. So we really are grateful to the NMDP and for ESTCT for helping us figure out these guidelines, because it's not clear what to do, but these will be evolving. And there is a page on the ASTCT website to go to start to talk about this. But again, these things are evolving. I wanted to move a little bit on to CAR T because this is something that's a little bit different from transplant, but has a cellular therapy basis. As most of you know, chimeric antigen receptor T cell is a way for us to take autologous and sometimes allogeneic T cells and engineer them against a specific tumor antigen. And this has really become a very important part of therapy for non-Hodgkin lymphoma, and on clinical trials also being explored in myeloma. So let's first talk about standard of care CAR T therapy, because some patients with lymphoma are receiving this. Again, the basic triage question comes down to emergency or urgency. And so if this patient was planned for CAR T and there really isn't anything else for them to receive, and they seem to be having disease that's progressing or in a clinical need, we will proceed with both the apheresis and the administration. Again, you can sometimes think about separating out the cell collection, which is what is needed in order to make the CAR T, from the actual treatment. And some patients were in that position when all of this started, where the cells had been collected and were being engineered, but then unable to be given because there was the crisis emerged. In this situation, we have been allowing definitely for collection because it's a lower risk procedure. And then when it comes to giving the cell, again, we've been pacing it on urgency. Because most CAR T patients right now are in the multiply relapse setting, we are allowing them to proceed with the CAR T therapy. And one thing that we've had to make sure of is that our hospital has tocilizumab, because this has also been thought about as far as treatment for COVID. And now there is sort of a shortage of toci. So you have to make sure that your hospital is ready to give toci and has that allocated for the patients that are being planned for CAR T. Finally, I want to say for clinical trial, although we all want to put patients on clinical trial for CAR T, this has been a little bit challenging because clinical trials have other rules, for example, research labs and other extended procedures that are difficult to do in this setting. Because of that, some of the larger companies have actually said there's a halt in enrollment for new patients on their trials, and they're going to assess this in a week-by-week situation. And similarly for us, we also want to give CAR T if it's possible for life-saving, but we also don't want to compromise any rules of an investigation, which may change data outcome or safety. Therefore, we've been working hand in hand with our pharma partners. With that, I'd like to close my section, and I will be happy to take your questions later at the end of the session.
Dr. Shah, that was fantastic. A really nice overview. Thank you. There is the issue with tocilizumab is something that I want to get back to at the end of the program, because that is becoming an important part of all of this. So thanks a lot. Next, we're going to have Dr. Saad Osmani, who's a myeloma expert, to provide us with an overview about the management of patients with multiple myeloma. Dr. Osmani.
Thank you so much for having me on this panel, and for having me follow Nina. She set up this nicely. for this overall discussion. So, you know, in terms of management of plasma cell disorders patients in general, for multiple myeloma, we recognize following patients in the early stages of disease before progression, as well as when they get newly diagnosed. And then the treatment becomes a little bit more challenging as they go through their first and subsequent relapses. You know, COVID-19 has affected how we are managing and following these patients throughout that whole natural history or schema of disease. For M smoldering patients, you know, we have been doing more virtual visits and frequent lab follow-up. The only patients we're paying a little bit attention to the labs, and I guess still having a little bit more you know, focus on their clinical picture is the high-risk smoldering myeloma patients, because they're just teetering at the edge of turning into active disease. And there appears more of a thin fine line now than it used to be 5 or 6 years ago, the way that we're finding high-risk smoldering and early active multiple myeloma. You know, regardless of the COVID-19 disease risk, the incidence of newly diagnosed myeloma requiring treatment is not changing. So, you know, we are still seeing newly diagnosed patients, but we are modifying their treatment regimens in such a way that we can reduce the likelihood of them coming into the infusion center. So, you know, we were already doing weekly Velcades. We are being a little bit more for patients who are getting carfilzomib-based induction regimens. We're modifying the dosing schedule to weekly schedule for those patients as well. And it's been pleasant to see that pharma is actually, our pharma colleagues are coming up with a little more leeway in prescribing immunomodulatory drugs. So as all of that, immunomodulatory drugs are regulated with the REMS program, but they have loosened up the criteria to allow us to give more than 1 month supply to eligible patients. And this is making things easy in giving patients less exposure to a COVID-19 environment. I have to give credit to our patients with newly diagnosed as well as relapsed refractory myeloma. They're already cognizant of the fact that they are immune compromised, and they are being extra careful in the current pandemic environment. So at least at our center and within our region, we're seeing less number of heme malignancy patients coming COVID-19 related symptoms or, you know, or being tested for it. So they'd be more careful than the healthier patient population. Nina already upon this, we are deferring autologous stem cell transplantation for most myeloma patients where we are doing stem cell collections. Now that we have the COVID-19 testing capabilities, we are also in the process of requiring patients who are coming in for their stem cell mobilization and collection or their auto or allo transplant COVID-19 testing, two negative tests 6 hours apart before they come into the hospital. We're doing something similar for our CAR-T as well. When patients get to the relapse refractory setting, this is where things are challenging because a lot of the clinical trial options that we had have been put on hold. CAR-T trials, some of the bispecifics and small molecules are still ongoing. The sponsors are now starting to allow virtual visits on some of those trials, which is helpful, especially in the beyond some follow-up time period. I think that's helpful for our investigator-initiated protocols. We've done the same thing for our patients. We've modified the treatment schedule to go less frequent infusions, requiring less labs, and allowing for virtual visits in patients who've already achieved a good response to therapy. And this way, minimizing their exposure to the healthcare setting. Beyond that, I'd be happy to hear what our other colleagues are doing in a similar setting. I share the same concerns that Nina had with the availability of TOSI or therapies. Our cumulative knowledge of COVID-19 disease is about 5. So all of us are learning from each other's experience. I'll stop right there and hand it over to Dr. Hussain.
Thank you. Dr. Ruga.
Sorry. Thanks very much. I have to remember to not be muted. There you go. That was great and really interesting, I think, to talk about some of the hematologic malignancies and the specific issues related to that. Remember to post your questions because I think there are a lot of questions that come up as we hear these talks that we can talk about in the Q&A with all our expert panel. So we're going to move on to a semi-solid malignancy, lymphoma, and Dr. Ajay Gopal will talk to us a little bit about this area. Ajay.
Thank you. Thanks for the opportunity to speak this morning. My name is Ajay Gopal. I'm a lymphoma doc and transplanter here at the University of Washington and Fred Hutchinson Cancer Research Center, and our clinic is the Seattle Cancer Care Alliance. So this morning I'll talk a little bit about our strategy for managing lymphomas with COVID-19 pandemic. And I think it's important, as my colleagues have noted, really this is a data-free area. I mean, we are trying to use our best guesses about how we should adapt our management to patients with the risk of COVID-19. That we will find out after the fact which approaches might have been best. So the general principles are that we want to maintain efficacy, we want to minimize the risk to the patients, and we also want to minimize risk to staff. We also want to conserve resources, both for our cancer patients, but importantly, conserve resources for our patients that we're treating for COVID-19. So with this in mind, we've adapted our approaches to the various lymphomas and other heme malignancies. I'm going to first talk a little bit about aggressive lymphoma. With aggressive lymphoma, we still maintain our curative intent. So we are not reducing our treatment. We are really trying to provide maximal supportive care. We may use growth factor support more often than we have in the past to try to reduce the risk of febrile neutropenia. When we have to use an intensified regimen, such as for a high-grade B-cell lymphoma, rather than using a regimen which requires inpatient hospitalization, we may use a regimen such as dose-adjusted R-EPOCH, which we can deliver as an outpatient, versus, for example, hyper-CVAD, which might be a bit more challenging to deliver as an outpatient. I think each center has their own approach. When we have our early stage disease, we also think of approaches that might reduce the number of cycles of chemotherapy. We know there are recent data, for example, from the FLIER trial suggesting that 4 cycles of R-CHOP with 2 additional of rituximab may be as effective as 6 cycles for select early stage patients. So we're keeping this in mind. As Dr. Shah pointed out, relapse does occur and transplant is a cornerstone of relapse. And this is really just a small window of opportunity sometimes to have another chance to cure patients with aggressive lymphomas. So we still are transplanting patients that are appropriate. For platinum-based salvage, we think of outpatient salvage regimens rather than rice, which may be given as an inpatient typically. We think of gemcitabine and platinum-based regimens, which can be given as an outpatient. And for those that are chemosensitive, we do still offer autologous transplant with all the precautions we can. Dr. Shah also touched on the use of CAR T cells, and I will concur with everything that she said. Each center is a bit specific. We are favoring the approach with standard of care regimen using the one that can be delivered as an outpatient, tisagenlecleucel, which can be delivered as an outpatient and tends to have a bit lower CRS rate and lower use of TOSI. So that's been the approach that we've favored. But again, this is just a center-specific thing. And for those that require further therapy, really we go into a palliative mode at that point. I'm going to, just for sake of time, talk about other major categories. I want to touch on indolent lymphomas, which is where I think we have changed our practice a little more. As we know, we don't treat patients with indolent lymphoma unless there's an indication for treatment, but that's kind of a gray area. And we've really tried to defer treatment initiation as long as possible, as long as reasonable, to try to get through this pandemic before we initiate therapy. When we do start therapy, we try to think of the least immunosuppressive approach. Sometimes single agent rituximab, lenalidomide rituximab is also a reasonable option. And then for the histologies where we can think of using agents such as ibrutinib, we try to use these agents, which are much less immunosuppressive. It can be administered orally, reduce the number of visits, and hopefully reduce the risk to patients. That's been our overall general strategy. I'd be happy to take any questions regarding our approach to treatment of lymphomas. Thank you.
Great, thanks a lot. Really appreciate it. We are getting a couple of questions, and obviously we've come up with some questions among the panelists. So we're going to be discussing several important issues. That's great. Now we're going to move a little bit towards solid tumors, and for that, we're going to start the discussion about management of patients with renal cell carcinoma. And we're very happy to have Dr. David McDermott joining us. Dr. McDermott, could you please start?
Sure. Thanks for the invite. I'm glad to be here. It's these types of forums where we're actually reliant on in our practice to learn from what other people are doing. And we've certainly adapted our practice over the last 4 to 6 weeks based on the input of other groups. I'm the chief of medical oncology here in Beth Israel Deaconess Medical Center, and I'm leader of the kidney cancer program at the Dana-Farber Harvard Cancer Center. And we've had, quite a few meetings, as I'm sure all of you have had, about management of our kidney cancer patients over the last month. And I want to share some of those decisions we've made about how we might change our algorithm, and also talk about a little bit about how our larger medical oncology group has tried to change practice to adjust. I think we've known for a while, that, as we all try to educate ourselves about COVID-19, that patients with a history of cancer are probably at greater risk of severe illness with COVID-19. I think the data there is obviously very limited, as with much that we have to rely on. To me, if that is true, it's not clear why it's true, meaning it's not clear, is it the risk factors that led to the cancer that put people at greater risk, or is it the cancer itself? Is it the immunosuppression that comes along with certain cancers, or the treatments that come along with certain cancers? I don't think we know the answers to many of those questions, but it's obviously made us try to adjust what we do in the clinic. I think one of the assumptions we've made, which may not be true, is that many of the standard kidney cancer regimens are not thought to be immunosuppressive. As you all know, most kidney cancer is treated with, some version of VEGF pathway blockade, PD-1 pathway blockade, and PD-1 based combinations, which have dramatically improved survival over recent years and actually led to some remissions in patients with the immune-based regimens. I think most of us assume that those approaches do not deliver the same level of immune suppression the way chemo might, or certainly transplant might. If anything, they're immune activating. So we haven't removed any of them from our algorithm for the most part, with a couple of exceptions. We've spent a lot of time talking about who to treat, sort of when to treat them. We have, as with many tumor types, different risk groups that we rely on based on prognostic factors. For most of our favorable risk patients, those are patients without symptoms. We are not initiating treatment, on diagnosis. We're observing those patients because we know they can be observed for quite a while without needing therapy. In asymptomatic patients, we're also skipping doses of immune therapy, like PD-1 based therapy, based on the assumption that even with these less frequent schedules, there's a long half-life with these drugs, and for asymptomatic patients who've been on therapy for a while, they probably don't need Q3 week or Q4 week dosing. They particularly at a time when many of our patients are afraid to come to the hospital. I think one of the adjustments that we've made, we tend to have an IO bias here at Beth Israel Deaconess, and there's two main choices in the front line: VEGF blockade with PD-1 or CTLA-4 blockade with PD-1. We've tended to go towards more CTLA-4 PD-1 in the pre-COVID era, largely because there's more data on long-term survival, which is obviously a primary endpoint for our patients, and the data about creating complete responses and potentially remissions of disease, so-called treatment-free survival, is encouraging. So we've been biased towards the IO combinations, but in this in the COVID world, we're using less CTLA-4 upfront. That's based on an assumption, based on the data that patients who are getting both CTLA-4 and PD-1 are at greater risk of significant immune-related toxicity, which more often requires steroids and sometimes admission to the hospital, neither of which are good for patients in the COVID era. So we're using IPI now in kidney cancer, at least in our practice, a little more as it's sometimes used with melanoma, which is used if PD-1 alone is not producing a favorable enough response, is sort of adding IPI later. There are several clinical trials that are looking at that concept. That'll be two of which will be presented at ASCO this year, the so-called Omnivore trial and the HCRN trial, and we're obviously going to see more data on that concept, but that's one of the approaches we've taken. Obviously, as far as oral drugs, there's many oral therapies for kidney cancer patients. We've not changed our use of those, but we are trying to provide them, we're trying to mail them to our patients so they don't have to come to clinic, as others have said, trying to do everything virtual as possible. So that requires setting up a new system for us for mailing patients their drugs so they can avoid coming to treatment now in the clinic. Now that said, I think, a lot of this assumes that coming to clinic is, we think, relatively safe for patients. That assumption may not be correct. And because we're doing limited testing on asymptomatic patients, we're not sure it's the right approach. My colleagues in Europe, many of them have stopped offering IV therapy to their patients. That we haven't gone there yet, but they have gone there with the assumption that, IV therapy can be harmful because it requires coming to clinic. Our clinic volumes are about 70 or 80% of what they were pre-COVID. We have not pulled back dramatically. That may turn out to be a good idea. That may turn out not to be a good idea. We'll have to wait. We sort of base that assumption based on trying to make the clinic safer. So moving towards what we've done in medical oncology, we've tried to emulate the Singapore model of cancer care, or sort of general care in the COVID era. This is a model that Atul Gawande wrote about in the New Yorker a couple of weeks ago, in a very interesting and easy to understand article, essentially trying to keep, as others have said, our staff and our patients safe, but also to keep open because, as many have discussed, a lot of cancer therapy is not elective. And so we've tried to limit the number of staff in the clinic, the number of patients. We've eliminated visitors in the clinic, which creates a lot of other issues. But the whole idea is trying to treat the smallest number of patients with the smallest number of staff at any one time. So as we're not spreading the virus to the staff, but we're also not acting as vectors of the virus while patients are in clinic, spreading it to them, because that's obviously an issue both ways. We've struggled to do that, at least in the beginning, because we had limits on our PPE, which many have faced. That's getting better. This would all be helped if we could do surveillance testing of COVID in the clinic, which we can't yet do, but hopefully that's coming in the next week or so. And we've created new units to keep our suspect patients with COVID out of clinic. So we stood up an urgent care, which I'm sure many of you had, but just have now, but just for our cancer patients. So anyone with suspect symptoms can come, get a test, get an evaluation, but not enter the clinic. We think that makes clinic more safe for the staff and the patients, but I can't prove that. We've also had more goals of care discussions, which really isn't a change in practice for us, but it's more of a reinforcement of what we should be doing all the time. But obviously people are busy, and goals of care discussions are not easy, and they're even more difficult in the COVID era. But given the fact that when patients get admitted to the hospital, they often lose contact with their loved ones, we felt that it was important to emphasize this before anyone got admitted. I'm not sure if that is right or wrong, but that's what we've been trying to do. So that's sort of how we've adapted both our kidney cancer practice and our medical oncology practice at Beth Israel Deaconess.
That's great. Really interesting discussion about this. And I think, the discussion about guidelines and what we're learning and modifying from people in other countries is also really important. I'm going to just briefly talk a little bit about breast cancer. We talked about it some last week also. and then we'll talk a little bit about lung cancer and go on to our Q&A. Breast cancer is the most common malignancy in women in the world, actually, although the survival is better in US, Europe, and some countries in Asia where there's access to many therapies. So we know a lot about access and timing and how it impacts outcome. We also generally, and this is similar to the renal cell discussion with David, that we think of our treatments as not being very immunosuppressive. We've looked a little bit at the data from Wuhan, and I think that the treatment and what's accessible to patients is quite different. In addition, I think the sort of setting in which treatment is being delivered is quite different in China. And so we've been trying to balance what we've seen in the multiple quick publications that have come out against what we've actually seen in practice, which is that generally our patients do well. They don't, knock on wood, die of influenza. We do make sure everybody's vaccinated, but still patients don't get vaccinated and they are not dying of influenza. We've sort of gotten from that most of our treatments are not very immunosuppressive. Of course, we have patients who are on immunosuppressive therapy for other diseases, and that impacts their outcome. So how can we take that information into what we recommend for our patients? And I think that we've all taken the approach of when we can think of a way to give treatment less frequently, or oral versus IV, or do video visits versus in-person visits, that we've taken that approach. For example, we have a setting where patients can go and get their treatment, but there's no inpatient facility. And many of our patients feel very comfortable going there. They'll go get their fulvestrant, their labs for their CDK4/6 inhibitor, and then go home. And on the same day, I'll do a video visit with them if we don't need to do an examination. And that's actually worked very well. It gives a lot of confidence to our patients. They feel comfortable, and maybe we'll be doing more of that even after the pandemic quiets down. There have been questions about whether or not we should be giving chemotherapy less frequently. I think that when we're treating in the palliative setting, I think this is a very reasonable approach with IV therapy. But in the curative setting, we've really maintained our same frequency of dosing and the same doses. The NCCN has put forth guidelines, and many different groups have, in the setting of COVID, of more frequent use of growth factors as an outpatient to keep people out of the hospital when we're giving more intensive chemotherapy regimens, that you might reduce actually the threshold for using long-acting and short-acting growth factors to be under 20%, so that if patients have a risk of febrile neutropenia of over 10% versus over 20%, you would use growth factors. And then I think another area which has been of great interest is when we should be giving, going directly to surgery. And this was discussed a little bit before in the setting of other cancers, but patients who have hormone receptor positive, low-grade, slow-growing cancers, small cancers, we've been taking the approach which has been endorsed by the guidelines to start with endocrine therapy and delay surgery for up to 3 months or so. We use neoadjuvant endocrine therapy. We know that this is safe, particularly for these small cancers. We do get into an issue when patients have very large palpable tumors, where we do want them to come in once a month to be able to evaluate their cancers and make sure they're not growing. And then in patients who are receiving neoadjuvant chemotherapy for aggressive hormone receptor positive, hormone receptor negative, or HER2 positive cancers, we've really continued the surgery at the same time point. So when you finish therapy, we go to surgery 4 to 6 weeks after the end of their systemic therapy. I don't think any of us feel comfortable continuing with antibodies alone, even in the setting of HER2 positive cancer, or in triple negative cancer, for example, waiting longer in patients who've had clinical CRs, because we know that these cancers can be really aggressive and change over the course of time. The other thing is just reassuring our patients about the cancer center and when they come in, how to manage things. We are doing very careful screening, as have all the centers now started, where patients are screened the day before. If they answer yes to any of the automated questions, they will receive a nurse call and a video visit, actually. We have a respiratory screening clinic where patients can be tested with a rapid turnaround time, or they can have an exam and chest x-ray and testing. And that's been great. I had a patient who had a fever after receiving paclitaxel and trastuzumab. We brought her in, we tested her, we had the test back within 24 hours, and we're able to continue her therapy. If you have any questions, if a patient did have a fever and they've tested negative, those patients come in with a mask. The other thing we've had is patients who've actually had an infection with COVID-19 and recovered. And when we start their therapy in a setting where we're really controlling their disease and allowing them to live without cancer, and that's actually been fascinating because there weren't any guidelines. So it's been interesting. And the guidelines have stated either 1 to 2 weeks without symptoms and at least 1 negative test. In some situations, people have wanted 2 negative tests, but with the limited access still to testing, we've had 1 negative test and a visit where a patient has no symptoms and at least 7 days with no symptoms prior to coming in. And those patients still wear a mask when they come in for their treatment. The last thing is somebody who's asymptomatic, who tests positive, who needs therapy, and what to do with those patients. And that's come up with our radiation oncologists, where they've actually designed a COVID testing area, a COVID positive treatment area, and be able to protect both the staff and the patients so that you don't interrupt curative therapy in the midst of the treatment. We actually have taken the approach of stopping treatment in patients who are infected, as I think most of my colleagues have and certainly can address in Q&A. So with that, I think I'll bring the speaker back to Dr. Hussein Bourais, who will talk about lung cancer a little bit, and then we'll go into the open Q&A.
Thank you, Dr. Rugo. I appreciate it. So I'm Hussein Bourais. I'm Chief of Thoracic Oncology at Fox Chase. I think in the last couple of weeks, we've talked a lot about lung cancer, but this is an evolving area. And I think, as you heard from the other colleagues, there seems to be an ever-changing practice pattern responding to the needs of the community and the needs of our patients. And it does appear that different centers in different parts of the country have different resources available. I think what is good is that we're noticing all the professional organizations coming up with specific recommendations for management of various patients. And the world of lung cancer, there are a couple of important issues that I think we should touch upon. And I'm not saying that I have an answer to all of this, but these are the kind of things that we're thinking about. One is the use of immunotherapy. As many of you are aware, the currently available checkpoint inhibitors play a major role in what we do in the world of lung cancer, very similar to what you heard from the renal cell world. Obviously, we don't have transplant issues, but we use a lot of the checkpoint inhibitors, both in terms of CTLA-4 and either PD-1, PD-L1. There are preclinical publications, some of them older publications, suggesting that perhaps the use of these agents could be associated with a more severe form of inflammation as a result of infection with COVID. We don't really have any clinical evidence or data for that at this point, but an HLH type syndrome has been postulated to possibly could occur. Again, we don't have any evidence of that, and I have to tell you that we're not withholding treatment with the checkpoint inhibitors when we think it's appropriate in a patient with metastatic disease who cannot really delay initiation of his or her treatment. But there's a theoretical risk that I think has to be discussed. As far as practice management and changes, obviously, as you heard from other colleagues, again, we are trying to limit the amount of exposure that a patient would have to, for instance, a waiting room, or even for that matter, in an infusion center. We do have some basic screening procedures in place, but knowing that a large proportion of patients could be infected without any symptoms, there's always a theoretical risk that, in a crowded environment, something bad could happen. But the screening methodology that we're using at this point with the questions and temperature checks seem to be fairly effective and uniform around the country now. Again, the effectiveness can be defined, and we can discuss that. But we are trying to adopt less frequent dosing of some of the agents that we use. For instance, there is a PK data that some of the currently available checkpoint inhibitors can be given every 4 to 6 weeks, as opposed to the traditional every 3-week schedule. We believe that for patients, or I believe for patients who have had stable disease and responding, doing well, perhaps adopting a less frequent dosing of some of these agents would be appropriate and something that we should consider. Again, we don't have specific guidelines. I don't have specific clinical data to prove that the effectiveness is the same, but knowing that these drugs have rather long half-lives for patients who are stable, perhaps a less frequent dosing would be appropriate, at least for this time. The issue with tocilizumab has been brought up a couple of times. We don't use tocilizumab that frequently in the world of lung cancer, but there are protocols very similar to CART programs that you've heard, and other potentially phase 1 trials where the protocol calls for availability of tocilizumab for treatment of patients if they have a cytokine storm or other issues. So those protocols, obviously, we're going to have to be careful how we open them, because we have a limited supply of tocilizumab at this point, or we're told that the supply is limited. Therefore, we have to pick and choose kind of carefully as to what we do. So, I mean, across different diseases, as you've heard since the beginning of the program today, we are adopting, we're changing our practice. We're trying to be responsive to the needs of our patients and to the situation on the ground. Again, different institutions and different regions in the country are facing different challenges and have different resources, but with the help of programs like this and other programs, and also with the help of our professional organizations, we're trying to come up with the best approach to the management of our patients. So I think with that in mind, I'd like to open the question and answer session. We've already received a number of questions from the participants online, and our panelists have been responding to some of the individual questions. But let me go to Dr. Rugo and see if she would like to bring at least one of the questions that we think are more broadly applicable up so that we can discuss it as a panel.
I think that's a great idea. And I will tell the audience that you can actually look at the Q&A and see the answered questions as well as the open questions. And these will all be posted after the session as well, which I think will be very useful. The first question, I think maybe Dr. McDermott can answer. David, the use of PD-1 CTLA-4 in favor of PD-1 alone is something that you discussed. You know, adding on CTLA-4 with poor responders or progression. Do you still use agents targeted to VEGF? Do you use chemotherapy in specific settings? How have you modified this even more in the setting of COVID? You're muted, so you have to unmute.
Sorry, kidney cancer is a chemo-free zone and has been for a while. As far as the use of the application of CTLA-4 or limited at the moment, we're assuming that over the next few months we'll get better at certain things, like, for example, understanding which patients have COVID and which don't, you know, understanding who's been exposed and who's not in the clinic. And we hope to be able to go back to using CTLA-4 relatively soon, you know, but that's an assumption. And the reason for holding it is also based on a sort of an assumption that based on our experience, the data, adding CTLA-4 increases the risk of both needing immunosuppression and hospitalization, which we're obviously trying to avoid. I think there's a big debate about which approach is better in kidney cancer. PD-1 based therapy is the standard of care in the front line for most patients, but the question is, what's the combining partner? Is it VEGF or is it CTLA-4? Most people, particularly in the community, use PD-1 VEGF, and that is a totally appropriate approach and doesn't need to be altered. If that's your approach, that does not need to be altered in our minds in this era. But that said, I think what we like about IO is it, at least at the moment, produces better endpoints that we care about, like long-term overall survival, complete response rate, quality of life. But that said, the story with Axi-Pembro, for example, is very impressive. You know, higher response rates, higher median PFS. I guess it depends on what you prefer what your goal is for your patient. Our goals tend to be more based on those endpoints that you get with immune therapy, but it's a debate. There's no head-to-head data, so it's more religion than science at the moment.
It's really interesting. I know that there was an interesting question for Haas. Maybe you could answer the next question about whether you're delaying adjuvant chemotherapy, and another question about consolidative durvalumab after radiation and CT.
Yeah, actually, I was just typing. The question came from Dr. Corey Langer, one of the top international experts in the world of lung cancer. So I'm happy that he's joined our discussion. I think that's an important question, right? So my approach is that for patients with curative intent treatment, I try not to delay treatment because, it's a curative intent. We don't get a lot of that in the world of lung cancer. But with that being said, in the adjuvant chemotherapy world for lung cancer, there is data that even up to about 4 months post-operatively might be safe to give the adjuvant chemo. So in a case like what we're facing now, I am willing to delay the treatment, but not significantly. Again, if we think, in my view, treatment is with curative intent, I think there is a timeline as to how much you can actually delay the treatment. Same thing with durvalumab. Again, the data that we have at this point suggests that this is a very effective treatment after chemotherapy and radiation. And even though these are advanced stage patients with locally advanced disease after chemotherapy, radiation, and all of that, the intent again is to have cure rates. Therefore, I think delaying it beyond a couple of weeks or several weeks might be harmful. But the good thing is that at least in the world of durvalumab, there might be a possibility of giving the drug less frequently. And that is what I was referring to in my section about management of patients with lung cancer. So instead of every 2-week dosing, it might be reasonable to consider, at least for the time being, every 4-week dosing based on some of the PK data and all of that. Again, we don't have clinical evidence that the efficacy is the same, but we know, again, that these antibodies have a long half-life, so there is a possibility that we can do that. I don't want to give the false information to our participants. This is not an FDA-approved regimen. This is not, again, something that I have clinical papers for. We're just trying to adjust to the situation that we're facing at this point. And it is something that I am considering adopting in my clinical practice. But again, these are the kind of questions that I don't think we're going to have clinical trial data in time to direct us. And we're trying to learn from each other, discussing it with other experts, and relying on professional organizations to help us with their best practices.
It's really interesting that I think people have been thinking about giving antibodies in particular less frequently because of the long half-life, and trying to understand how that impacts outcome is going to be really fascinating over looking at patients over time. I think, for our patients who are working in heme malignancies, patients get a lot of their treatment in the hospital. We talked about trying to treat as an outpatient for as long as possible, but most of you said that if you needed to admit, and if somebody has an urgent need for transplant, they come in the hospital. Or of course, if they have with questions about how to deal with patients who are facing more end-of-life discussions, because sometimes, patients look like they're going to do great, obviously, and the unexpected can happen. Nina, how are you managing that at UCSF?
Yeah, this is a really important discussion, not just for hematologic malignancies, but all malignancies. And there are those discussions that you have in advance of any chemotherapy or procedure or surgery or whatever, and say, okay, there are risks and benefits. But this truly is more important now than ever to have discussion in clinic before there's chemotherapy, certainly high-risk chemotherapy or transplant, or if there's a situation where you feel the patient is deteriorating and is getting admitted for sort of that last chemotherapy attempt. These discussions have got to be had in the clinic with the patient, and even actually in advance with the patient in the clinic, maybe with another family member over Zoom or whatever capabilities you have before you get inpatient. And the reason is that, as many of you know, there are limitations to how many other family members can come in. Even if the patient is COVID negative, we're just trying to limit the traffic of people into the hospital. So it's really important to talk and actually document all of this, because sometimes you're not the person taking care of the person in the patient in the hospital, right? It might be a different team. And if your colleague knows that you've had this conversation, documented, who is the point of contact, who can you Zoom in at that time, even in the inpatient setting, it will make the experience a lot less anxiety. Of course, you can never anxiety provoking. Of course, you can never predict everything bad that will or won't happen. And that's just tough. And I think that's on us to provide patients with a little bit more emotional and comfortable support during this time where they can't be in person with their family members during very difficult times. And that's a hard thing to do with all of us being stretched so thin. And I know it's hard for me too, but really trying to invoke our palliative care services and whatever we can, so patients don't feel isolated in this very difficult end of life time.
Yeah. Hope, there are a couple of questions regarding the use of HER2-directed therapies for patients with breast cancer. Could you address some of the issues? Again, are you doing less frequent dosing? How long are you continuing? There are multiple questions regarding all of that.
Yeah, I was just answering that one question. I think that, antibodies have a long half-life. Patients who are receiving adjuvant trastuzumab and pertuzumab or trastuzumab alone, there have been a lot of questions about the appropriate duration. And for a patient, for example, who you're treating with stage 1 HER2-positive breast cancer, I think that you could make the decision, for example, to stop trastuzumab at 6 months. There is actually quite a lot of data that the treatment is quite effective in lower risk disease at 6 months, and we don't know that people need a year of therapy. When we're giving trastuzumab and pertuzumab, or for example, TDM1, we've continued with an every 3-week dosing schedule. I think if you have a patient on long-term maintenance in the metastatic setting and you want to delay till 4 weeks, we really have zero information about how this impacts their outcome. But if they've been on long-term therapy and they're stable, I think it would be reasonable to consider treating every 4 weeks. At the moment, certainly in our practice, we've continued every 3-week dosing because the number of missed visits with every 4 weeks is fairly low, and they can come in on Saturday morning when it's a very light number of patients there, particularly now, and be fairly secure in terms of the safety of coming in and getting treated. So that's what our approach has been so far, but I think that you could make a decision to treat every 4 weeks. We haven't stopped therapy in patients who have disease control. There's always this issue of should you be treating when patients are 10 years out from metastatic disease? And there, I think you could safely hold treatment.
Yeah. So let me go back to the issue of shortages of some drugs and things like that. I think I haven't heard of shortage of chemotherapy drugs that we commonly use or the checkpoint inhibitor, so that's what I'm not talking about. The question of tocilizumab being a little bit on a shorter supply, or there might be a problem, has been raised, and we've discussed it briefly. I think we need to go back to it. And I guess one of my other questions is that there are a couple of different anti-IL-6 antibodies that are potentially available. Are we married to tocilizumab, for those of you who use these a lot? Well, the transplant or in the renal cell carcinoma, or do we think that we can use other anti-IL-6 out there? So let's start with Dr. McDermott to see if he has any comments on that, and then we can go around and see if anybody else has experiences with other drugs in that category. So please, David.
Right, so most of my experience is anecdotal. And we started hearing these anecdotes a few weeks ago from colleagues in Italy who were using it in some of their patients. One of my melanoma colleagues, Paolo Acierto, sent around an email that sort of highlighted some of their experience. In Italy's, I believe that Roche was actually supplying the tocilizumab for some patients, and so they had access to it. And they reported, several impressive recoveries of patients as giving it as they were becoming hypoxemic. It seemed to reverse the course in some patients. Most of that data is not published, although they're trying to put it together. I think SITC, which is the Society of Immunotherapy and Cancer, put out a white paper on the subject, largely based on that experience. I think it was last week. So if those want more, anyone who wants more details about what's known, the SITC paper is a useful place. Obviously, you need randomized trials for proof, but it seems like with the cytokine storm, it might ameliorate that, that ARDS-like outcome in some patients. And, as we spread the word, we get more anecdotes, but obviously randomized trials are what we really need for these novel therapies.
A quick question, just to ask you, Huss, very quickly. Somebody brought up, which I think is interesting, and I don't know the answer to it. If you give antibodies every 4 weeks versus every 2 weeks, do you double the dose?
Not necessarily. I think there are some dosing differences for some of the antibodies. And again, that's one of the questions that I don't really have a clear answer to. But at this point, I'm not sure what happens in terms of toxicities and things like that if we go around and double the dose of every antibody that we're using just because we're doing every 4 to 6 weeks dosing. Some of the antibodies actually have data for less frequent dosing with a different amount of the drug, but not everybody has that at this point. But it's not exactly like a doubling. I don't think it works quite that way. The other questions that have come up again in terms of treatment management, again, for solid tumors and for heme malignancies, there's obviously significant differences in the drugs that are that. But for instance, in our world, we use a lot of chemo combined with immunotherapy in some of the patient populations that we are dealing with. So the question has come up, should we separate them now because of this question about checkpoint inhibitors being associated with worsening inflammatory responses if somebody gets COVID? For our colleagues in the world of lymphoma and myeloma, are you trying to adjust those kinds of treatments, meaning sort of decide which one might be better tolerable right now? Are you adjusting the way you are using the drugs in your sort of armamentarium for management of these patients? So maybe AJ, you want to start with that?
Sure. Yeah. I mean, I think it's really just hypothetical at this point whether anti-PD-1 therapy increases the risk, and we do use it in patients with Hodgkin lymphoma and primary mediastinal B-cell lymphoma, for example. So we are still using that, and we would typically favor that over a chemotherapy-based approach. We are reducing the dosing frequency as needed. There's probably not as much of a dose-response effect with these drugs. We are really trying to reduce the lymphotoxic drugs. And another mention is rituximab maintenance therapy. There's really no data in indolent lymphoma that there's a survival advantage for rituximab maintenance. So we are halting all of our rituximab and obinutuzumab maintenance to try to allow some B-cell recovery in those patients.
Okay, anybody else, Dr. Shah?
So yeah, this has been a question about, for example, daratumumab, which can be sort of a chronic every month therapy. And some people have put off a cycle here and there. I think in the case of myeloma, which is like I said, a marathon disease, and you have to always keep that clone down, I'm a little hesitant to skip more than one dose of this monthly therapy. I think, I gave patients a pass for 1 month when everything was sort of blowing up. And now I feel that we've mitigated risk enough at the clinic with all our screening that I feel it's okay for patients to come in. And I really think something like sub-Q daratumumab is going to change this, because the area under the curve of time will change that. Maybe Dr. Usmani can talk about that since he's the lead on that.
Dr. Usmani?
Yes, I think, having the subcutaneous formulation, which should be becoming available, fairly soon. We just had the paper come out in Lancet Heme maybe a week or two ago. But we're just waiting for the FDA nod. I think that will reduce that exposure period that patients may have. I echo what Nina said. In a disease where we do not have a curative intent, and we're simply maintaining the best response, I think continuing therapy as less frequent schedule as possible would be important. I think one thing that hasn't been touched upon, and I just wanted to mention this, is the use of steroids in myeloma regimens. I think many of us have started to dial down the dosing of dexamethasone or discontinuing it in the maintenance phase of treatment, or even for patients who are relapse refractory and have had decent disease response and have been on a regimen for a little while, just to give them less immunosuppression during the time of COVID.
Yeah, that's really interesting. I think that, the question about how we're rearranging care has been fascinating and really a big issue for all of us. I think another issue for most of us is the clinical trials and how we're managing clinical trials. We've heard that many institutions have closed their trials completely, but a lot of us are trying to keep at least some trials open. I'm interested to hear how people are dealing with research biopsies and blood that's drawn for research-only purposes. In our institution, our clinical research coordinators are working from home, and we've employed DocuSign for our consents and for evaluating toxicity. And actually, it's my hope we might be able to continue using DocuSign. I think it's a lot nicer than getting a huge pack of paper to sign and evaluate attribution. So that's actually an interesting area, but we're right now not able to do biopsies for research-only purposes or draw blood for research-only purposes, with the exception of screening. So I'm interested in what everybody else has been doing in their programs. Saad or Ajay or anyone?
I can certainly speak. We have a weekly update with all the various disease leads for research, where we kind of make sure we're all on the same page regarding strategy. But we're not doing research-only biopsies and blood draws unless it is needed to make some treatment decision about a dose of a research drug or something along those lines. So we're really not doing that. Our phase 1 trials, for the most part, with the exception of patients that have already consented prior to this, and we're waiting for a slot, we're really not accruing to the first-in-human type phase 1 trials. We're also dialing back our phase 3 trials if there's true equipoise between the two arms, between a standard of care versus an investigational arms. The phase 2 trials we're cautiously accruing to, and likewise we're getting our coordinators out of the clinic and really trying to limit exposure.
So let me say something.
So
hold on for a second. I'm
Go
sorry.
ahead.
So I think we all have had to adjust the way we do trials. I think, again, Dr. Langer has a very good question here. All these blood draws and visits and things like that. So there are a couple of things I think that we can address, right? The studies that we're in control of, obviously we're cutting down the number of visits that we think are not necessary. And to be honest with you, as investigator-initiated studies, when we write these trials, we have these things in mind, and we don't try to have day 1, 8, 5, 15, all of those visits in there if we don't really think it's necessary. In terms of the specific questions for Insigna, which is a large national ECOG and SWOG collaborative work, we followed the NCI guidelines and recommendations. We're allowing for patients to have televisits when appropriate, come to the office less frequently. The study was written such that we don't have a lot of unnecessary blood draws or visits in there. What we've done in our institution, much like what you heard, is that, for instance, phase 1 trials with first-in-human drugs seem to have a lot more visits associated with them for safety measures. So some of those studies are probably a little bit impractical right now. If a patient has to come in daily for several days for EKGs, blood draws, visits, and all of that. So I think we are backing off either activating or enrolling on these phase 1s with a lot of visits and all of that. For many others, so if it's a phase 3 study, randomization to standard of care versus a new drug plus a standard of care, those are fairly straightforward. I think it is reasonable to proceed with enrollment on those types of studies, again, with caveats that if a patient cannot get in, or if a patient has an outfit for blood draws closer or radiographic imaging closer, then maybe that should be the practice. I don't think we have to put a hold on all clinical trials across the country. I think we can be a little bit more careful as to what we open and what we offer to our patients, but I don't think this means that the entire clinical trial operation all over the country has to be shut down necessarily. So at least that's the tack we have taken at Fox Chase, and that's the way we are trying to manage our trials. There's definitely less people being screened. There's no doubt about that. But I think you can pick and choose what studies are manageable given the current situation.
Yeah, I kind of echo what you're saying. And the way that we have approached this is, if there's a reasonable standard of care available for the patient, which avoids them coming into the cancer center more frequently, we will offer it to patients. But if the clinical trials are a better option for that patient, we are going to be offering it to them. I think, Nina can kind of vouch for that. A lot of us bulk of our patients are in the relapse refractory setting, and they're coming to see us for that, next wave of clinical trials that's going to keep them going. So we're still keeping those clinical trials. There's certainly less a number of patients being screened, but we are keeping those options open. Now, the challenge for us is, almost all the CAR-T trials are on hold right now, at least in the myeloma space. So the options we have are bispecific studies, and many of them actually require between 24 to 72-hour observation period in the hospital. And so, with this surge, another 2 or 2.5 weeks away from us, for us, the challenge is, all the hospitals are trying to limit the number of beds being utilized right now, anticipating that volume coming in. So we have to be, more stringent in shepherding those clinical trials so that, we're not exposing our patients to the risk of COVID-19 during the surge. I think that's a challenge that all of centers, have to accommodate for too.
Yeah, I just want to add to what oh, sorry. I really have to applaud a lot of our industry collaborators because they've tried to help us to figure out what's the best. Sometimes it's hard to know what the best thing is. I will say even some of the smaller companies have been very helpful, understanding they have a drug that might really make a difference for this one patient. So the phase 1s, et cetera, they're willing to take the hit and not get the PK result if you think that drug is going to help a patient and you think you can safely give it. And that's why we're still seeing referrals for clinical trials. And there are maybe 1 or 2 CAR-T companies that I can think of that are still allowing enrollment. And the question is, will they allow your site to enroll if your site cannot do the research labs that are required? So even though at a company level, they will allow it, the question is, will your site allow it, or will the company allow it with your site's limitations? So it's all a case-by-case decisions. So I would still refer people for clinical trials. We can do a lot of the initial consultation on Zoom, and then decide if we have something that would fit and make it worth the patient's time and exposure risk to come to the center centrally.
It's a really good point, actually. I think that, we've seen in breast cancer, some of the registration trials, the phase 3 studies, actually closed temporarily to accrual to try and prevent the loss of data. So it's interesting. Some people have taken the approach, for example, if you're doing a phase 1 trial or a trial where there aren't other options and it's a single arm trial, of keeping open for the registration phase 3 trials, either mandating that you follow specifically, you have to be at a center where you can follow the specific procedures required, or temporarily holding to accrual, which is an interesting question. We have had a lot of interest in, and we've talked a lot this morning about ways that we've been trying to modify our treatment and thinking to respond to the pandemic, to protect our patients, and to limit the use of limited resources such as PPE, or the need for aerosolized treatments, bronchodilation, and surgery suites. our guidelines have really come out with a lot of temporary guideline and temporary approaches to this. And it's been interesting, actually, on the NCCN guidelines, there's actually a COVID button so that you can go there and, it's clear that this isn't like our guidelines forever. This is our guidelines in the pandemic. And people have really come together to create those so that there's ASCO and NCCN guidelines, as well as many other societies. And I wondered if people might talk a little bit about how those guidelines are impacting our treatment now, and which ones you have found particularly useful. David?
Yeah, so I think the guideline discussions are similar to, in some ways, to this discussion today, which is depending on where you feel you are in the pandemic, in the course of the pandemic, that influences how you adjust your practice. So it's not easy to get, at least in the discussions I've been part of, to get a firm consensus on what to do with what patients. You end up with more suggestions than firm opinions about how you should modify the guidelines. I know the NCCN went through the effort of modifying the melanoma guidelines, which are helpful. There's a similar effort for kidney cancer. I'm sure they're for all tumor types. Those are helpful, but the NCCN guidelines in general tend, at least in my opinion, which maybe I should keep to myself, tend to be a little bit broad, at least in the tumors that I treat. So you can rely on guidelines, and there are groups out there that are helpful, but ultimately it comes down to discussions that are both global and local about how to do these things. And I don't think there are firm answers. I mean, I think one of the things I've struggled with giving advice and making decisions is almost every piece of advice you can give, every plan you can make has at least one obvious problem with it. It's like, so for example, we've talked about keeping patients out of clinic, and because we think that's good for them, and not coming to the clinic, not coming in to potentially be exposed. But there are lots of patients who are very anxious about not being able to come to clinic, not being able to see their care team, not be able to see their treatment nurse. And by creating these sort of broad policies, we've found we have patients who really appreciate it. There's certain patients who really like the telehealth visits and may never go back to the old way. But there's others who really are feeling, that it's anxiety provoking enough to have cancer. And then when you're separated from the people you're counting on to help you, it makes it worse. So that's one of the challenges I've had with coming up with firm guidelines is there's no piece of advice that you can apply to every situation, I found.
I think it kind of answers questions for where there is no answer. And it does help people a lot who, for example, are treating many different cancers. So,
right. Agreed.
Haas, I'll turn it over to you.
No, I was going to say, I absolutely agree with David. I think some of the guidelines have to be broad. I mean, they're guidelines. You have to keep them in mind, but you can adjust them to where you're practicing and how your practice is. It's very difficult to write specific recommendations for every single type of practice. I mean, again, it is just not possible to consider every scenario and come up with exactly what you do. So I think guidelines are designed to be broad, to provide a basis for us to work with and to have discussions with our patients. I think in all of this, again, we keep emphasizing treating patients, but I think responding to the needs of the patients becomes really, really important. I mean, they have a lot of questions, a lot of concerns about drug shortages, and we get that question a lot. And I think we try to address those to the best that we can. Obviously, our patient advocacy groups do a really good job of informing patients about what the potential drug shortages might be or what the alternatives are. So I think they function in a world where we're not necessarily in it as heavily. So I think working with patient advocacy groups within our own institutions to provide what resources we have available to us for our patients becomes a really important component of what we're doing now to communicate issues with a broader patient population. So I think we need to applaud the effort that our patient advocacy groups have put into all of this. I think this really has been a great discussion. Where we had a lot of good questions submitted, some of which we answered sort of online, some that we've been able to answer here. I think I'd like to go around the table here, so to speak, virtual table, and sort of ask everybody to have final comments about where we are, where you think we're going to be going, and we're going to try to end it on that. So I'll start asking Dr. Shah for her final thoughts, and then we go through it. And Dr. Rugo, you'll be the last to close the session for us. So Dr. Shah?
Okay.
Yeah, thanks so much for having me, and I really hope this was valuable to some of the participants and the audience members. I want to say we don't know what, these are uncertain times, and so we don't know what's going to happen, but I also want to give this glimmer of hope. During every crisis, something new comes out. I think one of the things I'm really hoping for, just my own little hope, is that we're going to change how we practice medicine to be more patient-friendly, research trials to be more internet-friendly, really getting rid of a lot of paperwork that isn't necessary. And these seem like small things, but over time they will change the finances of how we provide care and do research. So that's my hope that we'll get out of this. Of course, hoping and praying for everyone to stay healthy during this time.
Thank you. Dr. Gopal?
I also just thank for the opportunity to speak and really echo what Dr. Shah said. We've learned a lot, and we will continue to learn a tremendous amount about how to best care for our patients, what is patient-friendly, patient-centered, and really how to do things efficiently. It was just remarkable. I'm sure we can all give many examples at our centers, processes that might have taken months to try to get started. All of a sudden, within a matter of days to weeks, we have an urgent care clinic, or we have some other specific clinical support structure. And I'm hoping that we can learn from this to be more efficient, to really focus on our patients and advancing the field with research in really the best way possible, and removing bureaucracy. But so I'm quite hopeful. I think we're going to come through this as a better society, a stronger society, and better practitioners.
Great, thank you. Dr. Osmani?
Yeah, I'm going to echo what Dina and Ajay have already said. I think out of any adversity, that's actually a breeding ground for innovation and collaboration. And what we've seen over the past 4 weeks in our healthcare system is, getting rid of silo mentality, breaking down barriers, and trying to come together as a community to find answers for our patients. The pace with which we were able to get some of very unique models up and running, like a virtual hospital to care for COVID-19 patients at home who are not sick enough. And then, collaboration across the different institutes within the healthcare system was quite phenomenal. So I think, we are going to come out stronger and more efficient at the end of this as a healthcare community. And I think we can probably drive down the healthcare cost in general, with some of these initiatives.
Great, thank you. Dr. McDermott?
So thanks again for the invite. I learned a lot by listening to my colleagues and the questions today. And, I think these forums are very important because this is not just an area that's changing rapidly. Every day we have a new assumption or a new piece of information that changes our thinking. But it's also probably going to be a longer haul than many of us would like, which is, particularly in the healthcare space where our patients are going to be dealing with these challenges that we've talked about today. Like, is it safe to come to clinic? Is it safe to be treated? And our views on these are going to change. But I'd echo what others have said. I think we need to rely on 2 things. One, science and data. We have a lot of anecdotes. We're relying on each other for help, but we have to test these ideas and make sure we can sort of prove that they are good and they're not harming patients, and they're not creating models that are isolating. And then we need to rely on each other. It's the only way we're going to get through this. And it's been very exciting to me. How is the fear that's driving through everyone, both the clinicians and the patients, has really been motivating people to work together. But it's going to be a long ride. So we need to keep that up and keep our focus on the future and how we build a stronger society, a stronger healthcare network together.
Thank you so much. And before Dr. Rugo goes, I'd like to thank our colleagues at Axiom, specifically Mr. Hafiz Sikter, Ms. Michelle Dickinson, and others behind the scene who on a weekly basis devote a lot of their time to putting this program together. So thank you very much. And to all of our colleagues today on the panel, I really appreciate your help and your participation. It was great. And with that, I'd like to hand it over to Dr. Rugo for her closing remarks.
Thanks very much. And again, just to echo the thanks to everyone it's just, I think one of the most amazing things for me in this pandemic, which is such an unprecedented and first experience for all of us, is the tremendous community outpouring of support, both from our larger communities, but within the medical community. All of our providers, our nurses, nurse practitioners, our hospital staff, and our administrators have really come together to support our patients and support treatment of patients within the oncologic community and, of course, the larger community as well. It's really, I think, been incredible to me to see via our Zoom conversations within our own institution, everybody coming together and talking in a way that we just hadn't before. In terms of our care, really thinking about our planning for every single patient, again, working together as a community to devise the best plans. And then I think in terms of clinical research, really going back and questioning how we're managing things. It's going to be a bit of a slippery slope as things open up, not to just fall back into the same patterns. And I think that we're all going to have to work together to try and really think about how we're impacting our patients in clinical research and treatment, and how best to do things that really matter and not to just do things because you're copying and pasting from the last study onward. So, you know, if anything tells us about people's commitment and passion to oncology, it's people donating their time on Saturdays to have this broader discussion. So I want to thank everybody who's been on the panel, my co-chair, Haas, and to Axiom for doing these programs, which have been so informative and fabulous, and then are posted on the web so that if you didn't hear all of the program, or for your colleagues who didn't participate who want to see both our conversations within chat as well as the live discussion, you can do so by clicking on the link that will be provided to you. Thanks very much. Have a wonderful weekend and stay safe.